Thank you, Stan, and I'd like to thank the event organizers for actually putting together such a wonderful event. I'm hoping that you're all having a great meeting so far, and I'll try to share with you some of the clinical perspectives that a physician brings to SRS cases, a radiosurgeon's perspective, and then after I finish, my wonderful physics colleague, Dr. Winston Wen, will tell you how it actually happens. So we have a lot of ground to cover. I'm trying to give you a 30,000-foot view of how we handle intracranial and spine stereotactic treatments. In terms of disclosures, we get research funding from Varian and Phillips. I'm also involved in the state medical societies and radiologic societies. The objectives are going to be to understand the indications and selection of patients with brain mets or benign brain tumors for SRS, and indication and selection of patients for spine SRS, and the types of techniques that are used in terms of treating those patients, and dose selection. So we'll start with brain mets. This is just a general slide. I like to always stress that the most important thing is to make sure you get the immobilization and set up right before you start treating a patient. You're not going to be able to make up for it at the end. I think everyone in this room appreciates that. Having the right imaging is always important. When you're going to do radiosurgery work, you want to make sure you have the best anatomical information you can have to delineate your targets as well as your normal structures. And you want to be able to select your dose based on what your clinical objectives are. And certainly you have to have a robust QA and delivery program, because you're dealing with doses that can be extremely toxic to adjacent critical structures. When we talk about radiosurgery for brain mets, we look at the solitary met, the multiple met scenario, how many is many, the large brain mets, how large is large, what about the post-op stereotactic scenario. And we'll just look at, these are the treatment options that we consider, and I'm sure they're similar in your institutions. When you have a patient who has multiple mets, poor performance status, KPS is Karnofsky performance status, you're thinking whole brain as their treatment option. It's very palliative in nature, and it has the toxicity of cognitive neurotoxicity. When you have a few lesions or up to 4 lesions, depending on the shape, the location, radiosurgery is a very strong option to consider for those patients. You have greater than 90% tumor control rates. It's a non-invasive option. It's very convenient, one or a few sessions for the patient. The risk, however, is radionecrosis, and that's where dose selection becomes important, and other therapies that they may be on, considering those things becomes important. For lesions that are very large, when there's a neurologic deficit, surgery followed by radiosurgery is an option. Again, local control greater than 90%. The challenge is it's an invasive procedure. Remember, we're trying to do radiosurgery to minimize invasion for the patient. In this case, you'll do the surgery and often need radiation afterwards, and you still have the challenge of radionecrosis. So the solitary met, when there's no tissue diagnosis, or there is mass effect causing neurologic deficit, or you have a lesion much larger than 3 cm, surgical resection is what's preferred. When that is not the case, or you have a medically inoperable patient, radiosurgery is a preferred option, at least at our institution. Now, we define the large met as greater than 3 cm, or a lesion volume of greater than 20 cc's. And if you meet both criteria, usually I will not do a single fraction radiosurgery. I might do fractionated stereotactic, or we'll opt to send the patient for surgery and consider surgery followed by SRS or whole brain, depending on the pathology, SRS alone, or whole brain by itself. Here's an example of a large met. This was 3.5 cm in size. You can see the radiosurgery planning CT with the dose distribution and the target volume. After 2 months, there was fantastic response in the lesion, and then at 1 year, you just see residual scar tissue, no even evidence of any residual edema or change. This is a larger lesion where we opted to have surgery first. There was mass effect here, the ventricles, horn was being compressed, the patient was symptomatic, there was quite a bit of edema. It was resected, and then we treated it with the post-op SRS target. And I apologize, that's just a cartoon circle. The actual contours were a little tighter on that. And that's a 6-month post-op image. And you can see that the lateral horn of the ventricle is opened up, and there's no edema or scar tissue left there. In our experience, for the large lesion, local control is about 84% at 6 months, 3/4 at about 1 year, and 2/3 at 2 years. The overall median survival for these patients is about 7.5 months. In terms of complications, 4% have acute worsening of their existing symptoms. That is, we're not able to get enough decompression to minimize the deficit or the change they have, and they end up having to either go to surgery or best supportive care. 16% have scar tissue or radiation effect, and half of those, it's radionecrosis that requires either long-term steroids or requires other medical management. and very rarely surgery. So how do we select our dose? The first thing is looking at the goal of treatment. Are you trying to get a complete response to a solitary lesion? Are you trying to stabilize the patient? What's your expectation? What's the histology that you're dealing with? Is it something that is classically sensitive or classically resistant? How big is the lesion? What are the local OARs? Is this in an eloquent area close to, say, the brainstem or the speech or motor centers? Or is it kind of in free space, so to speak, in the brain? And then you look at the patient. Can they tolerate the stimulation? Are they able to comply with the recommendations that are being made? So in our process, when we were developing our program, we actually looked at RTOG 9005 to come up with our dose selection. And the guidance you get from there, and you can see the data in the table on the far right of the screen, but for up to 2 cm lesions, you can use 24 gray. Between 2.1 and 3 cm, 18 gray. 3.1 and 4 cm, 15 gray. Now, there's no reason to push to the maximum tolerated dose. The local control is still 90% plus. So our preference is to use 18 gray as our standard dose to prescribe to the 90% isodose line using a linear accelerator-based delivery. And if the lesion is larger, we'll use 16 gray as opposed to 15 gray. So here's the first SAM question. For a 2.5 centimeter brain metastasis, the maximum tolerated radiosurgical dose based on the RTOG 9005 would be 1, 24 gray, 2, 20 gray, 3, 18 gray, 4, 16 gray, 5, 15 gray. The clock is timing down. Great, so you are listening to what I'm saying, it's great. That is the correct answer. Very good, fantastic. Next question is, once we know what dose we're considering, how do you define your volume? What are we going to actually include in this case? And do you add a margin? Do you add a CTV margin, a PTV margin, a setup margin, dose fall-off? How do you take into account all those factors? And here I have a cartoon showing an actual midbrain brainstem lesion with 3 different contour sets. The first one's supposed to represent a large, generous margin created around what's contrast enhancing. The second one is supposed to be a small margin, although it looks tighter than I would have wanted. And the last one is you draw with inside the contrast enhancement. So the argument that you're trying to deliver your treatment dose inside the contrast enhancement and neglecting anything that may be immediately in the periphery. We at our institution do not add a generic margin, an algorithmic margin of 1 or 2 millimeters or 3 millimeters. The clinician constructs it, and you can look at this case right here. See if I can use the mouse just to point this out. But if I put a generic margin around here, I might go into this CSF space. And there's no disease that's going to be floating in that CSF space. That's just a waste of trying to account for dose in that region. But if I know that the tracks here run along this axis, I might want to add a clinical margin here or a clinical margin this way, not crossing midline into the other side. Okay? So those are considerations that go into learning how to construct your margin. A clinical margin, not a generic recipe margin. When we were trying to get guidance on how we were going to approach this, we were looking at it from a histopathological perspective. What happens when you take samples of the brain tissue? Is it that the met grows and pushes the brain parenchyma away, or does it grow and have satellites around it? And this is from Baumert's work that he published in the Red Journal. But you can see here, this is the nodule, the melanoma nodule, and within it, its vicinity, there's this little microsatellite deposit. Same thing with this non-small cell lung cancer and these microsatellites. So if we could look at samples, and that's what Baumert and his group did, could we get a sense of what kind of distribution, what's the depth of infiltration around these lesions? And here you see non-small cell lung cancer, small cell lung cancer, non-small cell, small cell sarcoma, melanoma, and breast cancer. And for the majority, the range is 1.5 millimeters or less. Now, melanoma has a broader distribution, as well as small cell. Now, historically, small cell lung cancer, you think of it as a very systemic disease. You don't typically use radiosurgery up front. You do whole brain because you anticipate there is more disease than you see on your imaging studies. So here's the next SAM question. In defining the clinical target volume for SRS of brain metastases, the maximum depth of infiltration was shown for which histology? Non-small cell lung cancer, sarcoma, renal cell cancer, breast cancer, or melanoma? Okay. The answer is melanoma. It was small cell was the other one. Small cell, not non-small cell. Now we go back to how do we define that contour? Taking that knowledge that we have about how that disease may be around the contrast-enhancing lesion, our practice is that you draw to the contrast just outside the contrast enhancement. So how do I practically do that? I'll change my brush tool so that I cover the contrast enhancement and then add 1 millimeter to 1.5 millimeters all around that. So I'm tight but not too tight on it, okay? For the post-op case, it's a little different. There you're going to cover the contrast enhancement, any residual tumor that you have, and then add a few millimeters margin because you don't know how the anatomy has been disrupted and how it's changed since the surgery, okay? And here we show you an example where there was a gross residual nodule as well as a resected cavity. The surgeon wasn't able to take all the disease given the risk to the patient. And so we gave 16 gray to the resected cavity and 18 gray to the gross nodule. And our practice, again, for SRS alone is 18 gray is the preferred dose to the 90% isodose line to the contrast-enhancing lesion. For surgery followed by SRS, it's 16 gray is the preferred dose, where you have the surgical cavity, any residual contrast enhancement, plus a few millimeters constructed around it. Now, I said that I changed my brush tool. One quick solution is one could add a generic expansion, but then you have to clinically modify that to take into account the natural boundaries that exist. There's no additional planning margin that's used, and then the techniques, my colleague Winston Wen will go over all the different techniques that are available when we go to plan these cases. In terms of imaging, if the patient has had surgery, I prefer to get repeat imaging 2 weeks after the surgery. It's not uncommon to have a cavity collapse on itself. It's not uncommon to have new tumor progress or the edge to get thicker. So you want the patient to heal from the surgery. That's where your 7 to 10 days comes post-op. But you want to get repeat imaging so that you're not contouring or missing disease in the process. For the SRS alone cases, the risk of new intracranial mets is about 40%. So this is not the target of our treatment anywhere else in the brain parenchyma. The time to that's about 4 to 5 months. So these patients are often getting MRI images on a 1 to 2 month basis. Half of those patients will be salvaged with SRS. So they'll have 1 or 2 or a few lesions present in that follow-up period. And about 35–40% will have multiple lesions present themselves, and then we'll get whole brain. The overall survival is, again, 7 to 8 months. Here's a comparison between the literature and our experience. You can see when you do surgery plus whole brain, local control is about 90%. The risk of new mets is 15%, but there's cognitive risk there. The patients have cognitive decline. If you do surgery alone, it's inadequate. It's only 54% local control. New mets, 35% risk. If you do SRS and whole brain, while you have the same kind of local control you'd expect for surgery in whole brain, that is, the SRS is in lieu of a surgery, the risk is, again, that you still have the risk of cognitive deficit in that patient. SRS alone is about 70%. This is over 2 years. But you have the ability to offer SRS treatment as new mets pop up as long as you're doing close interval follow-up. And our experience has been local control rate about 90% with SRS alone, about 90% with surgery followed by SRS. And the survival is between 7 and 8 months. In the surgery followed by SRS case, it was about 10 months, but it wasn't statistically different for the series. Now we move on to benign brain tumors. And we're going to talk about meningiomas, acoustic neuromas, pituitary tumors, and then one giant cell tumor case. Here, the goals of treatment are a little different. So in mets, we're trying to control or obliterate a met that's symptomatic. Here, we're trying to stop tumor growth, preserve their neurologic function, or improve their neurologic function, and certainly preserve their quality of life. These are people who have a benign condition. Maybe a meningioma was found incidentally. Maybe they had a symptom from it, headache, whatnot. We certainly don't want to aggravate their quality of life with our treatment. So the treatment options for meningioma are surgery, embolization, or radiation, and that can be done in a conventional fractionated course, 25 to 30 fractions, or we can use stereotactic radiosurgery. And there's a lot of literature, this is not nearly comprehensive, looking at using radiosurgery to treat meningiomas. And you can see that the control rates are about 90% or higher. In the case where all the way at the bottom you see in a malignant meningioma, which behaves more like a malignant process, the control rate is a little lower. So for meningiomas, grade 1 meningiomas, the option is surgery or radiosurgery. Grade 2, it's external beam to the surgical bed, or radiosurgery, if you've had a good resection, you have a small contrast-enhancing residual. And grade 3 is often external beam with or without a systemic therapy to the surgical bed. In terms of doses, we use doses between 14 and 16 gray, very rarely 18. And I would say the majority of cases are around 14 gray. The volume is the contrast-enhancing mass. We do not chase the dural tail. Because when you chase the dural tail, you have the risk of it progressing along the dural tail is very low, but you're covering intervening brain parenchyma that's adjacent to it. So you certainly are increasing your risk of toxicity without actually assuring any better local control. We don't add a margin. We do not include the edema from the meningioma. These tend not to be invasive, so there's no reason to cover the brain parenchyma where you see edema. The tumor control rate, or that is lack of progression, is greater than 90%. And you can get shrinkage in about a third of the cases, significant shrinkage in about a third. Here's an example of a meningioma that we treated with 16 gray, and you can see on these axial and coronal images that it showed signs of shrinking even at 2 months. Here's one that was in the pineal region, and it was treated with 14 gray, and you can see that in the 9-month image, there was some increase in edema adjacent to the area of the meningioma, but that resolved over the course of the year, and the lesion stayed stable to slightly decreased in size. Here's a gentleman who had a meningioma adjacent to the brainstem causing cranial neuropathies. He received treatment, there was decompression, and his tongue started to function better. His cranial neuropathy got improved. Next, acoustic neuromas. Microsurgery versus SRS are really the two big treatment options that are available. These are not trivial surgeries, and there is risk to the patient's normal function. So many of the cases, patients will come to us for the radiosurgical option. There's an interesting story when Kanziolka was presenting at a conference of neurosurgeons. He presented 5 MRI images of acoustic neuromas, and they polled the audience to say, what option would you pick? And I think 98% of the surgeons came back with surgery. Then he asked the 5 neurosurgeons whose MRIs he had displayed to stand up and tell the audience what they actually received. And they all chose to go with radiosurgery. The radiosurgical dose is 12 to 13 gray, rarely 14. We do not go to 14 gray. You increase the risk of toxicity without any improved benefit in local control. So we try to stay around 12 to 13. The contrast enhancing mass is the target volume. There's no margin added, and we do not chase the nerve. And I'll show you why we do not chase the nerves. Your typical MR series, it's very difficult, first of all, to carve out the facial nerve. You can use special sequences of MRIs, and really it's just a thin-cut acoustic series, so you can have the resolution and see the nerves, but you still don't chase the nerve. And in terms of constraints, the most critical structure that you're trying to protect is the brainstem. You want to keep the dose below 10 gray as a tolerance dose, certainly even as a point dose. Although some lesions, the larger lesions, you can allow the max point dose to the brainstem to float higher than 10 gray. So here's work by Flickinger just to kind of go over why we don't increase the dose and why we don't track the nerves. So here you see the risk of neuropathy with the 15 gray dose. This was prescribed to the 50% isodose line in their gamma knife patients and 80% isodose line, I believe, in the Linac patients. And so you can see as you chase the nerve length, whether it's cranial nerve 7, 8, or 5, the risk of toxicity goes up. So we don't chase the nerve length. In terms of dose selection, let's say that we pick a 2 centimeter, it's a relatively large acoustic neuroma, and we look at 12 gray, the risk to their hearing is about 20%. And then you can see 14, and as we progress up, certainly as the size of the lesion increases, the risk, regardless of the dose, increases. And when lesions are 4 cm or larger, we typically will send them to neurosurgery to get the maximum decompression off of the brainstem as quickly as possible. And over here in this data, we see how this is the 12 gray mark. This is the range of data that they had, the risk of neuropathy as a function of dose. So that the guidance for the 12 to 13 gray really comes from this experience. When we tell patients about these options, you always want to be very conservative about what you recommend. And tumor control is about 90% on either side. In the best neurosurgeon's hands, they'll swear it's 97%. And in the best radiosurgeon's hands, we'll swear it's 98% because we're better than the neurosurgeons. The hearing preservation is about 2/3 in either case. The real difference, and this is the difference for the patient, is the risk to the facial, causing facial weakness. It's often double or more with the surgeons. These are conservative numbers. Some surgeons will say that they can do much better than this, but in many series, you'll find 30–40% risk for facial weakness. The risk of imbalance is of less than 5% in both cases. Now here's a case that we treated with 12 gray. You can see before the radiosurgery, the lesion itself. You can see the 12 gray was a prescription dose and the dose distribution immediately adjacent to the brainstem. And then you can see 8 months later, you can see essentially the contrast enhancement is decreasing, although the overall size appears larger than what was treated. This happens at about 5 to 15% of cases. It's not an evidence of treatment failure. It's not uncommon when you have that necrotic process happening that you may get some swelling. We reassure the patients that this is not unexpected. And often you'll see it resolve. And you see 18 months later, now the size has not dramatically changed, but certainly compared to the 8-month MRI, it has decreased. And the patient, it hasn't continued to progress, which is really what we're trying to achieve. Next, we move on to pituitary tumors. These are broken up into non-secreting versus secreting. And the difference there is because of the goal of the treatment. In a non-secreting tumor, you just want to stop its growth. You want to prevent it from causing further deficit in their function. Secreting tumors, you certainly want to stop its growth, but the larger challenge is reversing the endocrinopathy, the abnormal endocrine function. And that depends on the type of hormone that's being abnormally produced. Those are the ranges that we see for endocrine tumors that produce growth hormone, anywhere from 55 to 90% control. Adrenocorticotropic hormone causing Cushing's syndrome, about 60% decreased rate. Prolactinomas or prolactin-secreting tumors, about 25% normalized, 55% have a decrease. And that often is the more challenging part because the consequences of having abnormal hormone production affect a patient's quality of life, their function, their longevity. When we're considering our dose considerations, the main structure that we're trying to protect is the optic chiasm. Sometimes these patients will present for the first time because they notice when they're sitting in the car, they don't see the person sitting next to them. They have the pituitary tumor growing, pressing on the optic chiasm, causing hemianopsia on both sides of their temporal vision. And so they'll go, and our goal then is still to preserve their function, maybe get some improvement, but now you're dealing with a tumor that's pressing immediately against the optic chiasm. And that becomes a significant consideration in terms of whether you can treat it radiosurgically in a single fraction. Do you have to do a fractionated course? The constraint we look at is tolerance dose of 8 gray and a max point dose of 10 gray, and max point here is defined as 0.035 cubic centimeters. You usually need a 2 or 3 millimeter gap. So when a patient comes to me, before I can actually look at what my dosimetric distribution will be, when I look at the coronal MRI, I'm looking for 2 or 3 millimeters between the chiasm and the tumor. If I have that, we can treat them in a single shot and with almost no risk to their optic structure. The cranial nerves that are immediately adjacent to the cavernous sinus tend to be quote unquote more tolerable. And that's just the clinician's way of saying, hey, we don't worry about them. We've never seen any cranial neuropathies from our radiation treating those nerves. For non-secreting tumors, we're trying to get a dose of 15 to 20 gray in there. For secreting, you want 20 to 25. And that's the challenge. If you're pressing on the optic chiasm, you're less than 2 or 3 millimeters away, and you're trying to give 20 gray there, but only 10. I think everyone in the audience here is very well aware that radiation just doesn't stop at that edge, right? And so that makes it very challenging. Here's an example of a young gentleman who had a prolactinoma. He received 20 gray. Now you can see in this image, There's the optic chiasm. This is the bulk of the tumor here. And here we're okay. Here we get a little too close for comfort. And what happens on the clinical side is you accept a little less coverage on this edge if for the bulk of this you're going to get your prescription dose in, if you're going to make your 90%, 95% coverage. And this is a few months later. You can see the tumor had shrunk. This prolactin level is pathologic, actually greater than 100 is pathologic, and he had come down significantly. And the last tumor is just a giant cell tumor. You can see here where it's disrupting this region. Now this case was very large, so we went with a fractionated course of 6 grade times 6, or we'll sometimes do 6 grade times 5. If they're malignant disorders, we'll do 8 grade times 4 to the lesion. This is 1 year later. And his cranial nervopathies had improved by that time. So let's move on to spine. So for spine tumors, just some epidemiology, about 25,000 metastatic spine tumors occur versus less than 5% of primary spinal tumors. So most of the time when we see spinal cord compression, we're thinking metastatic disease, not a primary tumor arising in the spine. About a third of these patients, cancer patients that we see, develop spine mets. A tenth of them will develop spinal cord compression. 20% will present with symptoms in their spine, be it pain or radiculopathy or weakness as the first presentation of their cancer. And 50% will have multiple levels involved, and about 3/4 the disease is in their thoracic spine and their T-spine. So how do these patients present? Again, 95% of them come in with back pain. And the challenge there is you may get cases where they had back pain for months, they're seeing their primary care. 70 million Americans have back pain because of musculoskeletal issues, not because of tumors. By the time they come to you, now they have a nerve deficit. And so we're not only trying to control their pain, we have to do something about the fact that they have decline in function. The late effects, as I mentioned, radicular pain, weakness, and then loss of bowel bladder function. Usually it progresses from pain, weakness, sensory dysfunction, sphincter dysfunction. And when you treat them, the order goes in reverse. So what's the workup? You always have to do a good history and physical, get a sense of what clinically they're presenting with, because I can't tell them what kind of improvement they had. I can't pick which of the multiple metastatic vertebral bodies is the one they're going to get the most benefit from treating unless I physically examine them. The imaging is not going to give me that information. The other thing is you need to have tissue diagnosis. Often we're pressed to have spinal cord compression, please treat them, but there's no cancer diagnosis. And I tell my residents and tell my colleagues, when tumor is the rumor, tissue is the issue, you need to have tissue because maybe the treatment will be very different. In terms of imaging, this is important. If we're thinking radiosurgery, we want the best imaging we can possibly get. If you're going to do radiosurgery for a spinal tumor that's pressing on the spinal cord, you need an MRI. You want T1, T2 series, you want contrast if the patient can tolerate it. You also need your CT, because if it's disease that's causing bony retropulsion, you may not pick that up on your MRI, but you look at your CAT scan and you see the bone adjacent to the cord. Well, I can decompress the tumor that put that piece of bone there, but I'm not going to pull and restabilize that piece of bone, so they may still have dysfunction. So you really want to complement those two imaging modalities. And if a patient can't tolerate an MRI, you really need to get a CT myelogram. You need to see the CSF space around the cord to get a sense of what kind of compression there is. Okay, here's an example of an MRI that shows a cord compression and then subsequent to the radiosurgery, the decompression, and a CT that shows a lytic lesion arising in a sclerotic bone met that responded to the radiosurgery. I always say MRI is not always better. Sometimes people say, I'll just use the MRI. You want both the MRI and the CAT scan. They complement one another. When we started developing our radiosurgery program, my mentor, Dr. Sam Yu, actually worked with our physics team to develop this program. And one of the first things was we have to partner with the neurosurgeons. When this patient comes in, they come into the emergency room, the neurosurgeon is going to get that call first. Which patients come our way, which patients go for neurosurgery? So we had to come up with a clinical way to grade these patients. And so we came up with an in-house grading system. Dr. Jack Rock and Dr. Sam Yu developed it. Sam always called it the in-house grading system, and I prefer calling it the U-Rock grading system. It's composed of a radiographic grade and a neurologic grade. And the radiographic grade is based on the location of the tumor relative to the spinal cord. If it's within the bone, it's a grade 0. If it's pressing the thecal sac, it's a grade 1. If it's compressing the thecal sac, it's a grade 2. If the spinal cord is impinged, it's grade 3. If the cord is displaced but the CSF is still getting around, it's a grade 4. And if the cord is displaced and there's no CSF, that's a grade 5. Neurologic grade is based on their function. No abnormality, it's an A. It's incidentally found, part of staging workup, whatnot. B is if they have pain. That's the bulk of the patients that we see. C is now they have some change in their function. They're not necessarily completely paralyzed, but there's a deficit. D is if they have a significant deficit in their motor function. And those patients often go to surgery because the fastest way to decompress the cord is still surgical debulking. And E is paralysis or loss of bowel bladder function. And these are just some examples of various radiographic grades of these types of tumors. So what are our treatment options for spinal cord tumors, or spinal cord compression? Steroids is the oldest option. It's immediate neurologic relief, but it's very short duration, and it's not oncologic for most of the tumors out there. There's external beam. That was a mainstay of therapy. It provided pain relief, neurologic improvement, non-invasive, but it did require 10 fractions. The pain recurred often, and the neurologic progression occurred as well. The other part was traditional fields knocked down a considerable portion of the bone marrow. When patients have spine mets, they already have metastatic disease. So you want to preserve as much of their bone marrow so they can get their chemotherapy, which is the real primary end of their treatment. And this radiosurgery certainly would have minimized that risk. Surgery is great because you get rapid neurologic improvement. You get tissue diagnosis, but it's invasive. They have to be able to reconstruct and stabilize that region. The patient needs to recover from it, and you have all the inherent morbidity and mortality of having the surgery. Now there's an option, vertebroplasty, where they'll inject cement into the diseased bone. You get pain relief from some stabilization, but it's not an oncologic treatment. And you can have chemical leakage or retropulsion of bone. So those are things that we try to avoid. So we were hoping when we were developing our radiosurgery program for spinal cord tumors that we would get rapid pain relief, neurologic improvement, spinal cord decompression in a non-invasive, convenient manner, one treatment for the patient, preserve as much of their bone marrow as possible because we would be only treating a very small volume, and hopefully allow them to quickly turn around to get their systemic therapy. The downside was that it doesn't improve spinal instability. So if you have a case where the vertebral body is literally like this, I might be able to treat the tumor that lies between those two fragments of the bone, but I can't pull it back like this. And so stabilization is one of the drawbacks or limits. To do this, though, you all understand the technical challenges to be able to deposit dose and protect an organ at risk that's immediately adjacent. So I always think that, if you give me enough beam elements, numbers, angles, whatnot, give me the technological ability to do radiosurgery, you'll certainly make me happy. And that's, I don't know about my physics team, but they've been very, very kind and worked with us to make this a reality. There's a capture from Brahme's paper in 1982 where you see a donut-shaped target around an OAR, and there's a screen capture of a slide from Dr. Yu and Dr. Yin's paper in 2001 showing how we use intensely modulated radiosurgery to treat a donut target with a spinal cord OAR in the middle. So it took nearly 20 years to go from theory to practice, but it did happen. When we define our contours, this was one of the first steps that you have to consider is if you have the technical feasibility to do the treatment, what are we going to contour? Are we going to just contour the gross disease that we see? Are we going to create a small clinical target volume around that and a planning target volume around that? What about the spinal cord? Are we going to put an OAR around it? How are we going to manage this? And what are the dosimetric consequences of these various iterations on providing adequate dose to the target but protecting the spinal cord? And what our practice has been, these are just 3 different sample examples of tumors. You can see on the one on the far left, the disease is primarily in the anterior portion of the vertebral body, and that's what a typical volume for us would look. We go partly into the towards the transverse process. We don't cover the entire bone. in the next case, instead of covering the entire bone when you have disease going into your transverse process, we still prefer to do this because embryologically, these elements arise differently than the anterior vertebral body and they grow together. So if you say you use a plane, you can just come up to this edge as opposed to covering this where you may not expect any disease here at any point. It becomes a planning challenge with the cord here. So there's little return for chasing back here. And in the case where the disease arises in the posterior element, just covering the posterior element into the pedicles. The other thing you have to consider is when we talk about the absolute constraint on the spinal cord, we have to consider variation within the patient. Here you see a case where the spinal cord runs closer to the vertebral bodies as we traverse down the patient. Of course, it's closest right where the disease is, and then it kind of falls further away. So you get this variation of the location of the cord within the patient, and you get variation in the size of the cord. Those are all going to be things that we have to account for. So if we have an absolute dose constraint, a max point dose, how are we going to account for this? The other thing is we're not drawing the entire cord. So when we said, okay, we're going to have to investigate this to come up with what our cord constraint is going to be, we're also going to have to investigate whether this is feasible or not. The first step was to do a phase 1 study and see that we have it is feasible for us to actually do this. Can we get the accuracy we need? The next part was, what's our first goal? Pain control is our first goal. So we escalated dose 10, 12, 14, 16, 18, and we found consistent pain control greater than 14 gray. The holy grail at that time was beyond pain control, can we get tumor control and epidural decompression, neurologic improvement? And for that, what we found in our experience was 18 gray or higher. This work led to the RTOG 0631 study, and now it's a multi-center trial where we're looking at both tumor decompression and pain control. So the first step, this is some of the initial work Dr. Yu and our team did back to show feasibility. We found our precision accuracy was about 1.3 millimeters. That was back then. We're sharper than that now. The dose fall off from 90 to 50% was about 5 millimeters back then, and we're close to 3 millimeters now with the new technology. In terms of efficacy, you find rapid pain relief in the majority of patients within the first 2 weeks. And that's a little different than using conventional treatment where you expect in a month you're going to feel better. You're going to get rapid pain relief within those first 2 weeks. And it's very durable. Even out to a year, about 85% have pain control. For the pain control, the dose, again, as I mentioned in the other slide, really when you get above 14, 16 gray, you plateau out. So if we go higher than 18 gray, we don't get much improvement in pain control, but the risk of compression fracture goes up, which is why we use 18 gray as our dose. Our risk of compression fracture is about 1 out of 7, 1 out of 8 for all our patients. And the bulk of that is driven by the patients with multiple myeloma or hepatocellular tumors, which is why we have not continued to escalate our dose for these patients. In terms of epidural decompression, now here you see a case. This is what the question that's being asked, right? The hypothesis was, will we be able to decompress this? To define that work, what we did is we did a small series. We defined the target volume as a gross visible epidural tumor, any paraspinal tumor, the involved vertebral body. The spinal cord was defined on the MRI images, and it was delineated 6 millimeters above and below the involved vertebral body. And that became our partial spinal cord volume. We found that for the first 85 lesions in the first 67 patients with a median follow-up about 6.5 months, the patients had decompression. I'll show you those results in a moment. We prescribed between 14 to 20 gray, 90% isodose line. Typically, there were 7 to 10 posterior IMRT beams that were used to deliver the treatment. And we set the spinal cord constraint based on Dr. Yu's work at that time to 10 gray to 10%. And you can see we were able to show epidural decompression. Here's one example. And you can see the thecal sac became more patent in that 2-month follow-up image. Overall, 65% epidural volume reduction occurred, so about 2/3 of the volume decreases. You can see those. And so we are actually able to show that we could decompress the spinal cord, improve the patient's pain, and improve their neurologic function, maintain their neurologic function. and keep them from having to have an invasive surgery. Here's a comparison. Now, there's no trial comparing spine surgery versus spine radiosurgery. You can imagine the ethical dilemma there. The patient sitting before you, they do not want the surgeon to cut their back, and now you're saying, I may give you an invasive treatment, I may give you a non-invasive treatment. But this is comparing to Patchell's work, and you can look, and you see that surgery followed by RT, overall ambulatory rates about 84%, radiosurgery about 80%. Ambulatory rates very similar in both, and then ambulatory function in the non-ambulating patient is also about the same. The difference, though, is, and here's an example, this is a patient who had an upper spine lesion, cervical spine lesion, was surgically decompressed. Now, you see this hardware here? That hardware is the support, the reconstruction after the surgery is done. This person will not be able to bend their head to say yes, okay? They will not be able to sip their morning coffee without using a straw. It's significant disruption of their normal function for the rest of their life. Whereas we could treat it radiosurgically, the patient gets the treatment and they go on, and physically they're no different. This requires weeks or days, weeks to rehabilitate, causes lifelong changes. And this, the patient comes in for a simulation, comes in for a treatment, goes on with the rest of their therapies. So in the randomized trial, again, it was designed so that we could compare radiosurgery versus traditional bone met treatment of 8 gray in a single fraction. There is crossover that's allowed. And the follow-up, we look at the pain score, quality of life, clinical and neuro exams, imaging studies every 2 months. And on the right of the screen, you see the various scenarios that we enroll in terms of diseased vertebral bodies immediately adjacent or 3 separate bodies. The constraints, so the contouring, you contour just the disease in the vertebral body. The cord is contoured using the T2 weighted MRI image. The constraint is 10 gray to less than 10% of the spinal cord, the partial volume, or 10 gray to the spinal cord volume of 0.35 cc's, or 14 gray to 0.035 cc's. So here's our final SAM for this session. The partial volume tolerance of the spinal cord for single fraction SRS is 1, 10 gray to 10%, 2, 14 gray to 10%, 3, 16 gray to 10%, 4, 18 gray to 10%, 5, 10 gray to 14%. Excellent, very good. The answer is 1, 10 gray to 10%. And again, it's 10 gray to 10% or 10 gray to 0.35 cc's or 14 gray to 0.035 cc's. The other part is when a plan is reviewed, often we look at our DVH. We're used to looking at our DVH, but things you have to consider when you're doing partial cord volumes is you don't want to have a situation where the DVHs don't look dramatically different, but instead of getting this kind of dose distribution into the cord, you have a spot like this. Now, I'm fortunate. I have a great physics team, so we're all checking on each other, making sure that Dr. Siddiqui didn't foolishly miss a segment of the spinal cord in his contouring because he was called or distracted for some reason, so that we don't end up with a scenario where dose blows out and causes harm to our patients. So the treatment of cord compression, Henry Ford, surgery for patients who have neurologic deficit, muscle power less than 3 or less, compression fracture with bony retropulsion, bone being pushed against the cord. Our radiation is not going to dissolve that bone. Not certainly any dose that would be safe in a patient. Spinal instability. And then for radiosurgery, pain with a power of 4 or more. And really, there's no upper limit on the amount of compression. I've seen patients who had a grade 5 compression, were functioning, started noticing some change in the neurologic function, were not surgical candidates. We offered them radiosurgery, and then they were back chopping their lumbar, a couple of weeks later. I'd like to close by acknowledging my physician colleagues, Dr. Mofsis, our wonderful chairman, Dr. Ajloni, Dr. Siddiqui, who do radiosurgery with me, and my wonderful physics team. This is only a small sampling of the wonderful physicists that we have and some of my radiosurgery therapists. Thank you so much. Sure, absolutely. I'd like to actually introduce my wonderful colleague, Dr. Winston Wen. He's the one who, is there a question?
Yes, quick question.
Yeah.
So for the Mets, where surgery and radiation are given, it's radiation after surgery.
Correct.
Is there a rationale for that? And I can see a rationale going the other way where treatment planning would be better.
So if you think about the context in which we send the patients for surgery, as I mentioned in the talk, was if they have mass effect that's causing a neurologic deficit. So we need to decompress that as fast as possible. And that's how it historically happened. So you had surgery, the surgery from after Patchell's work, surgery followed by whole brain was happening. Now surgery for patients who had solitary Mets that are causing mass effect still happens. And hence, instead of having whole brain after, it became radiosurgery after. It's really just how the program developed, so to speak, as opposed to a biological rationale. If you have a small enough lesion that has no mass effect, I think it's a great question to ask. You know, do you do the radiosurgery and then evacuate it, the tumor? It will give us biologic information about its responsiveness, right? And we might be able to use that to manage other Mets down the road. But that's not how the logistics played out in its development.